Today, you're caring for an 82-year-old post-op hip patient. Yesterday, she was chatty, knew her family, knew where she was, but today it's a different story. She's confused, pulling at her lines, asking to go home, and things just aren't right. Well, you've already identified that her problem is delirium. So the next question is, what's the plan? What do we do about it? Well, be sure to stick around. We can go through that whole case together. Well, this is where a lot of students freeze. They identify delirium and then they think, great, now what do we do? Right? Do we call the provider? Do we reorient? Do we ask for meds, labs? Well, it's normal to feel that way. There's a lot going on, and that's what makes it so tricky. So let's walk through a simple step-by-step way of handling your delirium plan so that it feels more intentional and not so chaotic. Tessa has created a wonderful visual aid for us today. She's showing you a picture of what I call safety and the 3 Ps, the delirium plan. First, we always want to make sure the patient is safe, especially when there's confusion involved. But next, we're going to try to identify the cause, provide comfort, and communication next. We're going to go through all of these steps together. Before we actually do anything, let's take a minute to pause. Scan the scene. Ask yourself, are they unstable? Are they oxygenating well? What are their vital signs? Are there any real obvious signs of delirium? Is there pain, hypoxia, and infection? That 10-second to pause will make all the difference. See that tiny pause? It keeps you from overreacting too quickly and responding without thinking. And that is how a real clinician responds. Good thinking, Nico. Those are both reasonable instincts. But first, we want to prioritize. Is this delirium patient stable or unstable? We want to ask questions like, is there hypoxia, hypotension, new neuro changes? If so, that will jump to the top. Well, once we've confirmed that they're stable, then the next thing is that we're going to head into our delirium plan. Safety and the 3 Cs that I mentioned. And Tessa has prepared another visual aid to help guide us through this section as well. All right, first we have safety. This is where we're going to take a look at things. Is the bed in low position? Did we set up the alarms? Did we remove any unnecessary lines or things that could be a problem? Have we thought about whether or not a sitter or family might be better in the room with the patient? So we're preventing falls and preventing them from pulling at any critical devices through this safety measurement. Next, we're going to take a look at the cause. What is going on that's causing a delirium symptom? So what do we do here? We check vital signs, check their oxygen level, do a pain assessment, evaluate what kind of medications they're on, what the lab values have shown, look for signs of infection. Is there any urinary retention or constipation? And remember, we're looking for a why. We're looking for the cause here. Next, we're heading into our non-drug strategies. We're going to be looking at things like glasses, hearing aids. What does the light in the room look like? Is it dark if it's nighttime? Do they have familiar objects? Is the environment calm? And these small things help provide comfort that are really powerful in delirium treatment. Next, we have communication. This is often an overlooked strategy, but we want to use short, simple sentences. Go through one thing at a time. Reassure the patient. Say things like, you're in the hospital and you had surgery. You're safe now. I'm here with you. Now with this next step, it's called proving whether it worked. This is one that many people miss, but I really love to sit back and think about did it work? Whatever we did, whatever interventions that we did it work? Did we find a cause? Did we provide comfort? And did we communicate well? Are we seeing signs of improvement, or are we seeing signs of decline? And how do we know this? It's through our reassessment. So sometimes reassessment isn't the right strategy, but it certainly is if you're trying to figure out if something worked. So the things we saw in the beginning, disorientation, is the patient now showing signs of being more oriented? Are they calm? Are they not pulling things off anymore? Has vital signs or lab values improved? Those are the things that help us figure out if a person is getting better, worse, or staying the same. Now let's walk it through with our hip surgery patient. We paused and we noticed sudden agitation and confusion. We checked the airway, breathing, circulation, vitals, oxygen, and pain. Next, we prioritized. This patient was hypertensive, but oxygenating well. No focal neurodeficits, they weren't crashing, but definitely were not okay. So we went on to the plan. First, we did the safety check. We put the bed low and the call light in reach, and we asked for a sitter to stay in the room with the patient. Next, we began looking for causes. We checked a pain score, reviewed meds for new sedatives or anticholinergics, and we looked for infectious signs. The non-drug comfort measures, we adjusted the lights, made sure the glasses were on, and we put a family photo in a visible place. Next, we looked at communication. The patient was calm, but needed repeated orientation to stay that way. And an hour later, we found that they were less agitated, their pain was better controlled, still a little bit confused, but much safer. That's evidence that the plan is moving in the right direction. Here's where a lot of students fall into a trap. They want to give the patient medications to calm them down. And calming them down is certainly important, but if you give medications too quickly, you might mask what's going on and delay the treatment, and that's not good for the patient in the long run. I certainly get it, Nico. I would want to calm them down too, and I'm sure that there's been many times where that's been my first instinct too. Well, you may not realize it, but what you just did is my 4 Ps. You paused, prioritized, planned, and proved. And you are moving yourself out of the stage where you hope you're getting it right to the stage where you're confident that you have got this. If you want to consistently think like a nurse and not memorize long lists, then stick around and watch another Deep Dive Sunday, which comes out every week. We're going to keep building your clinical brain one decision at a time.